Good afternoon, everyone. This is Gina. I'm with Aspen Ridge Recovery, and welcome to the Aspen Ridge Recovery webinar series. Today's presentation is on integrated approach for trauma and substance use treatment, and Danny Filippo is going to be our speaker today. For those of you that are familiar or not familiar with Aspen Ridge believes that mental health, trauma, and family are the root of recovery. We focus on healing these systems and provide each person with the tools they need to grow and sustain long-term recovery. With help, people with addiction, mental health, and trauma realize that they hold value and deserve to live with courage, purpose, and connection. Our vision is let's get real about behavioral health. We're expanding education, advocacy, and access. Just a few housekeeping rules in the very beginning. This will be a at least 45-minute webinar series to an hour. A follow-up online evaluation will be sent post-webinar. Please be sure to complete the online evaluation at the end of the webinar in order to receive your certificate. This webinar is approved for one NADAC CEU, so participants must participate in 45 minutes of this workshop in order for you to receive the NADAC credit. And a certificate will be emailed to you by Friday. If you don't receive the email, please let me know. And my email is down here at the bottom at gina.thorne@aspenridgerecovery.com. And now I'm going to go ahead and turn it over to Danny. Danny has worked in direct service with clients for the past 12 years and received his MA in counseling from the University of Colorado, Denver. He's duly licensed to treat both mental health and addiction and is certified in Brainspotting and integrated trauma therapy. Danny has provided trainings on crisis de-escalation, trauma-informed care, suicide intervention, and professional boundaries. He's currently the clinical director for Aspen Ridge Recovery, providing vision and leadership to the clinical team. At this point, I'm going to go ahead and stop sharing my screen and turn it over to Danny.
Hey there, really quick. Sorry, Danny, I don't want to interrupt. I got a message from a couple of people that say they're struggling to hear or they can't hear. So maybe test it out a little bit. Is this thing on?
Yeah, so I was just about to say that, Megan. So I could hear you much better. I think it may have been Gina's mic. Can people hear me okay? Loud and clear. Awesome. Cool. So I think we're good to go then. So I will go ahead and share my screen. All right. And let me get this presenting. Awesome. So, well, that's not how I want that to look. Let's go ahead and try that again. Hold on one second. This is exactly how you want trainings to start, by the way, in case you were wondering. All right. Awesome. I don't know why it keeps wanting to do that. Perfect. Okay, so we're going to start off with some definitions. And so with these definitions, really what we want to be doing is we want to make sure that we're all coming from the same place. So when I'm throwing out words such as addiction or substance use issues or trauma or stress or anxiety, whatever it may be that I'm referring to, that people know what I'm actually referring to rather than making assumptions. So in terms of addiction, generally speaking, I'm going to come from this definition. Oops, I'm sorry. So a chronic relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. When I talk about addiction, this is coming from National Institute on Drug Abuse. The reality is addiction can happen with behaviors as well. So it doesn't really have to be drug related, but I do think that overall that provides a pretty good definition. With that being said, you're going to hear me talk a lot about substance and substance use issues don't necessarily equal addiction. And so the DSM-5, how we're going about diagnosing a substance use disorder, isn't actually saying like, oh, this person has an addiction to alcohol, this person has an addiction to opiates. What they're saying is this person has an opiate use disorder and it is either mild, moderate, or severe, depending on how many criteria they've met within that. And so the reason why I think it's important to really clarify this is I don't want to create the misperception that when we talk about what substance is and how that interacts with trauma, that I'm creating this false narrative that, oh, unless it's an addiction, then it's not an issue, because that wouldn't be the case. There are many people who really struggle with severe consequences, including death, who did not have a severe substance disorder. And so with that, I'm one of the people where, like, in my head, oh, things are making sense. And so I want to make sure that what I'm communicating actually makes sense to other people. And then additionally, because I know what I'm talking about, but I don't know that you know what I'm talking about, you may hear me use words such as substance use, misuse, abuse, or dependence as well. And so those all just come from different spectrums that have been used at different points in time when it comes to supporting substance use. And so that use abuse dependence that you see there, that really was in the DSM-4. Actually, I really like that continuum, and dependence really being what that physiological piece. Misuse and abuse could be used by some synonymously. Um, However, when you really look at, like, when people talk about misuse versus abuse, if you want to get into the nitty gritty, misuse is often, your people who will occasionally use to excess for the purpose of being high. Abuse is really doing that on a more frequent occasion. Um, and so once again, just want to make sure that we have, like, a baseline of what we're talking about so that we are all on the same. I want to continue with the definitions, and here I'm really going to lean more into, I want to create the building blocks for what I truly lean into as trauma. And so starting with stress. I apologize. I'm currently sick. It's an awesome time to do a training, but it's where it's at. So stress. My body's currently stressed because I'm sick. But the definition that I like to use from stress, I actually stole directly from a professor. Um, and he described it actually as an organism's attempt to deal with the demands of the environment. With this, I stated brain and body's attempt to deal with the demands of the environment. A short version of that is, one, when I say brain and body, I say that because that's generally what people go to. Realistically, I believe that the brain and body are one, because brain is, at least in my body, I think. So maybe not right now, not feeling all there, but it should be one thing. Um, and so that aspect of stress is really deal with the demands of the environment. And so stress could really be thought of, oftentimes that external stress. What is it outside of us that is creating an adaptation, a response from us to deal with? And so stress oftentimes would be like, okay, so we uh we have something outside of us, and then when we either successfully deal with it or that stressor is no longer there, ideally the stress would go away to that stressor. And so an example of that is right now, right? Like, I get nervous talking in front of people. And so that's a natural stress. And so that would be external. And so after this, assuming that, like, okay, the jitters wear off and everything, and I'm like, okay, I calm down, that would show that that was really just the external stress. Anxiety is an emotional response to an unknown threat and is really more of that internal drive. And so stress and anxiety are generally talked about synonymously, and they are remarkably, remarkably similar. It is nuanced, different, and chemically pretty much identical, honestly, within the brain and body. Um, but we really, it's that internal drive. And so I'm someone who can struggle with imposter, right? And so while I do believe that I am someone who is good at my job and knows what they're doing, I still have this part of me of, like, who am I to be talking to these people about trauma and substance use? And so that is an internal narrative, right? That's internal driven, that is creating anxiety of, okay, well, what's going on? And that anxiety can continue even after me giving a webinar, because post webinar I could be like, oh well, yeah, why did you do that? Why would you agree to do this? Why would you sign up and want to put yourself out there, right? All these internal things keep it going past the exit. So stress, anxiety, once again, they're very, very similar. chemically, they're very, very similar. They're going to travel along the same pathways in the brain. They're going to release the same thing throughout the body. But it is more of like, what's the driving feature? The importance of stress and anxiety is they are really our building blocks. And so fear, we're going to use as an emotional response in the brain and body. It is really our alarm system, right? This is perceived danger, and perception is key. Real, like whether that threat is real or not, is not really necessary for fear. And so example is my partner and I, we were dead asleep one night, and there's just banging on the door out of nowhere, 2 a.m, dog starts barking. I jump up, my fear response is already activated. And so I look out, and like there are lights like trying to flash through outside of our window and everything. It turns out that the cops were at our door because they had my partner's plates wrong. They thought that like we had stolen the car. Weird situation. But anywho, the perception was that someone was trying to break into my house and harm my partner and myself. That fear, it didn't care about, okay, what is actually going on? It just cared in this immediate moment. You believe that the threat is real. And so with that, it's really the brain that is helping with that, of really providing context around it in that situation. And so like when we look at stress and anxiety and fear, we are looking at very, very similar chemicals, and honestly identical chemicals within the brain and the body, as well as very similar pathways within the brain and the body. But we are dealing with differences in intensity, and we are dealing with differences in terms of the brain's perception and the context of that event that really dictate which one of these buckets that we are going to be dealing with. All of these together then allow for us to build up trauma. So trauma is really when fear is activated in response to a traumatic event. And a traumatic event, like trauma, is relative. What may be traumatic to me may not be traumatic to you, and vice versa. And some people are more prone, if you will, to, or more sensitive to having a trauma response or response. And really what happens is that fear response that happens in that traumatic event essentially becomes ingrained in our nervous system. It gets locked in. And when it gets locked in, that is when it can happen. It could be activated, and that response can be activated when the time is no longer needed. And so I have this lovely tire track through the snow because this is a metaphor that I tend to use for trauma. So we're in Colorado. I don't know that everyone on this call is in Colorado, but haven't driven through the snow. That's what you could really look at, is we're going to have tire tracks going through the snow. And so one of our major highways around here is I-25. So if you're on I-25 and you're in the middle of a snowstorm and it's late at night, you're going to see something like, you're going to see well-worn tire tracks, and you won't see a lot of deviation, much like you have in this picture. That's because internally we go, oh, there's danger present. It is more dangerous to drive in this. And we see these tracks and our brain goes, you know what? These tracks are safe. They will keep us safe right now. So we're going to follow those tracks. And that makes a lot of sense when a danger is present. So we do exactly that. Trauma is when, okay, now I can melt the snow, but magically I can illuminate those tire tracks. And a person who's stuck in a trauma response will follow the illuminated tire tracks as opposed to the lanes that they could now see. And so those lanes may not correspond with the tire tracks that people were driving on when there was snow, because you couldn't see the lanes. And if I'm following those, obviously I'm causing destruction to myself, to others. It could be dangerous. And so essentially my nervous system is stuck back in time and responding to a danger that is not present. And so that is really how we're going to talk about trauma, is the nervous system. Excuse me. So what's going on in the brain with this? And spoiler, I'm not a neuroscientist. I'm someone who likes neuroscientists who could explain things to me in a very basic way that make me feel like I'm smarter than I actually am. So this is my basic understanding. And please know there's a lot more going on in the systems that I'm about to explain. And there's a lot more going on in the brain beyond the regions that I'm about to discuss. So when it comes to the amygdala, so it's part of the limbic system. And when I talk about these as well, this is our current understanding of the brain that is ever adjusting. 5 years from now, I hope that we have a whole radically new, not radically new, but a whole expanded view of what we're actually doing. But so one of the things for the amygdala is fear and threat detection and response. And I'm really going to lean into response in a moment. But so we have processing of stimuli as well as positive stimuli. We have that emotional memory storage. And so the amygdala is right next to the hippocampus, which is also involved in memory storage and recall. And so those emotional memories are very strongly tied to the amygdala. It's also part of why within that fear and threat detection, coupled with the emotional memory storage, why some of these negative memories take such a strong hold with us. If we think about a car crash as an example for a trauma, it's not often that I'm working with someone who initially comes into my office and they're experiencing PTSD symptoms for a car crash, and they talk to me about all the positive experiences they've had in a car. The brain is not focused on those at that point. That one intense emotional memory is really what's locking in the brain. And so really strong in terms of how we can have that emotional storage. And of course, there are positive versions of that too. And then additionally, the amygdala, so when I say that like and response, it's underlined, it's also responsible for sending signals out. We're going to get to the hype in a bit. But realistically, that's to the adrenals and it's stress hormones. They're going to be released there. Additionally, there's a period aqueductal gray, PAG, and I will absolutely lean into the acronym rather than the actual word, as well as the dopamine system. The PAG, what's really important here is that's believed to be very important to the freeze response, right? And so when people talk about trauma responses, you've probably heard fight, flight, freeze, appease, or some variation of those four. And so that freeze is really aligned with the and the adrenals are really more aligned with the fight and the flight. And then so the reason why I've really highlighted response is the amygdala will allow for reflex. And so what I mean by that is because we have these intense emotional storage and we are sending signals out, once we have this storage, we have our reflex of, oh, I'm going to respond just like that. And it's a very strong system that is very generalizable. And so, for example, like I could sneak up behind somebody and I could like, poke them with a needle on their elbow and the reflex happens, right? It just goes, it shoots out. So probably do that with an ice cube or something cold and wet, or something that just feels weird, not even necessarily hurts, but the reflex would be activated. And so that just shows a little bit of that generalizability that can happen within our systems. And so the importance of that generalizability is, as I talked about, it's not just responding to that threat that may not even be present anymore, but we can generalize it to seemingly unrelated things, much as like in that classical idea of things. So someone may, I'll continue with the car crash, right? So we have someone who was in a car crash and well, so maybe this specific song was on and that song is now a trigger, but maybe it's even generalized beyond that of like, well, actually this was a country song. Now I can't listen to country music anymore. And I'd be sitting there of like, well, that sounds like a win, but still it's not really relevant to the actual danger of country music did not cause it. Country music, much as I dislike it, is not dangerous. And so with that, that's kind of that generalized point. Um, the hippocampus is also involved, as I said, in memory storage and is playing a pretty big role in what's going on in trauma. And so we we know that it's involved in memory consolidation, so short-term memory. And really what's amazing about it is it helps us understand context of memories. And so really part of what it's doing in that context is it helps us differentiate. And one of the things, I believe there's actually multiple areas in the brain that do this, but it's part of a system that helps us to understand of a memory. Is this happening presently or is this in the past? And so that is obviously key when it comes to that trauma response. And so what we will notice with people who've experienced trauma and struggle with chronic stress, they have decreased volume of their hippocampus. And so that decrease in volume, it is I don't know if deep functional, but it's not functioning at its full capacity. And so we actually are losing that capacity, and it's a system that feeds itself, right? If you have a hippocampus, and part of what it does is help us remember, okay, this is present, this is past, this is how you need to respond based on that context. When we have a system that's damaged, we are actually more likely to respond in a dramatic way. So as we have this trauma response, it actually feeds that idea that we continue to respond in a dramatic manner. I hope I'm making sense so far. I trust that people, if they have questions, that they're just putting in the chat, and that Gina or Megan could just let me know. Let's see. And I actually don't have my chat open. Cool. Now I do. That'll help me keep. So with all of that in mind, the hypothalamus, this, as I was talking about, that HPA axis that I talked about and is also in this slide. Oh, what is it called? The hypothalamic pituitary adrenal axis, I believe. So these two are really relating to one another. The hypothalamus really regulates like a lot of our just basics, right? Release of hormones, controlling appetite, sexual behavior, stress response, body temperature. A lot of these like homeostasis elements that happen naturally within us. And so this is part of what gets activated. When I was saying that the amygdala is going to send signals out into the axis, that's really where it's going through. And it's creating this response so that when all that goes through here, the HPA axis is actually going in and saying, okay, adrenals go. And that is when your heart rate goes up. That's when you start sweating. That is when your blood is actually going to be like, okay, I need to get all of my limbs ready. And so the heart rate goes up, pumps blood to my arms, my hands, my feet. If I'm going to run, whatever I'm going to do, if I'm going to fight, it is ready to go for that. My eyes are going to be way, way more focused. My peripherals are going to go to poop. And that's really what it is. It's like, I need to focus on what is exactly in front of me so that I could survive right now. And so, once again, that is fear has been hit. Stress, you may notice some of that. Fear is really, we're activating more and more and more of it. And next. So, oh, there we go. And so I want to take what we are learning about trauma, and I really want to be able to tie this into, okay, so how are we, I'm going to be making this claim that we really need to be looking at treating substance use and trauma simultaneously. That is in the best interest. I need to now make a case as to why that is. And so I want to start with the ACEs study. So that was conducted, I believe started in 95 and like lasted 2 years or something. But the short version, well, I should, what ACE stands for. So ACE is adverse childhood experience. And so an adverse childhood experience, examples of that are like abuse or neglect or familial violence, being around mental illness, being around substance use or abuse, I should actually say, things along those lines. Actually, parental separation was one of them too. And it was a self-report survey of have you experienced? And they did this with 17,000 people. I believe they were all adults asking about their childhood. And Of that, I believe 2/3 of their respondents, roughly speaking, had at least one ACE. And what they noticed was that if you had experienced childhood experience, your likelihood for other risk factors, which they really talk about, and I'll go on to my next slide, um, increased. And as one would expect, the more ACEs that someone had experienced, the more likely they were to experience some of these risk factors. And these risk factors start to correlate with these diseases and early mortality. And as you can see within these risk factors, and this is not a full list, by the way, there are more. But as you can see, alcohol use, smoking, and that's referring to nicotine, illicit drug use, things along those lines were all risk factors for people who had experienced childhood experience. And so once again, those adverse childhood experiences could be traumatic. It's relative in terms of like, how do they feel about it? And how's that responded? And how has that sat in their nervous? Oh, excuse me. So when it comes to that, I did continue to like go through more and more data, and you know, there's huge ranges. If I'm being totally transparent in terms of the correlation between substances, and so I was seeing ranges from everywhere from 25 to 75%, and I just got to a place where I was like, you know what? And like like all these are accurate, and like let me just pull what we've seen over the past year. And so one of the questions that we ask is, have you experienced a traumatic experience? And it's they can respond yes, no, or unknown. And for all of our clients that we saw over the past year, out of those, 71% stated that they have experienced a traumatic event. 26% said that they have not, and 2% said that they were unsure. Of all of our intakes who had trauma listed as an identified 39% of all of our intakes had trauma listed as an identified problem. And so we do have that problem divvied out into two. That could be a unresolved childhood trauma, as well as post-traumatic stress disorder. But regardless, that really compiled into that data of trauma was listed as an identified problem that we were going to be working. 54% of people who reported having experienced a traumatic event had it listed as an identified problem, right? And so just because someone says like, yes, I have experienced a traumatic event, that might not be an active problem for them. That might be resolved, or they also might not view it as a problem, and it still may be. But of the people that had experienced it, 54%, it was an identified problem for them. So that's some of the real raw data that we have. Excuse me. So self-medication hypothesis. And you all are probably very well aware of this. It's not, well, I guess at this point it's not mind-blowing. Maybe it was when it first came out. But in short, it states that a person suffering is what leads them to it's going to drive substance use, short-term pain relief, because I'm experiencing pain. I don't know what to do with this pain, but I know what can help me stop it in the short. And so I'm going to self-medicate. And so when it did first come out, I believe it was in the mid 80s when it actually came out. But it really was drawn around this idea of moving away from pleasure seeking. And so the self-medication hypothesis has a backlash because obviously there is pleasure involved with substances. That being said, I would encourage everyone, like there are many hypotheses when it comes to substance use, and similar to like when we talk about nature and nurture, I believe you talk about it in nature and nurture. You don't talk about nature versus nurture. These aren't necessarily competitors. They're how do they work together? And I think the self-medication hypothesis really does a great job in talking about how someone would be motivated. And so when we talk about that pleasure, dopamine is often referred to as like the pleasure neurotransmitter. And so yes, dopamine is involved in pleasure and reward and things like that, but dopamine is really a survival mechanism. Dopamine is motivation. Dopamine is this, I'm having this feel good because it is a motivator for me to survive. And so that is how, when we are feeling in this traumatic place of, oh my goodness, I'm I don't know what to do with myself. I'm in fear for my life right now. And then we take something that relieves that, and it will activate our dopamine pathway. Then our brain goes, this is how you survive. And that is part of that cycle of how substance use and trauma really work together with it. And then it starts going into other models, such as the disease model and genetics model, right? Some people may have more of a predisposition to substance use issues. And as we use substances over time, that disease model of how our brain is changing and adapting to what we're putting in there obviously plays a role. And the self-medication hypothesis, I really do think, uh, has a good role to play here. And so that's one way that like we can see this relationship with substance use and trauma, right? I've experienced trauma. I don't know what to do, but this is one thing like I can do. And then it doesn't just have to be a one-way street. Not everyone who uses substances had like a traumatic experience, and it's like, oh, I'm going ahead and I'm going to start using now because of that. It's just not that predictable. But what we do know is we see these increase in risky behaviors shouldn't be surprising for anybody. And so as we start doing these more risky behaviors, as we start having a lack of an ability to cope with um, cognitive and social skills and the way in which we're interacting with our environment, we are actually more susceptible to experiencing trauma, right? So, we could just talk about substance use in and of itself. So, perhaps I didn't experience a traumatic event and I've been using substances and I did something to hurt my family or we lost our house or something like that. My substance use, because of my inability to cope and deal with other stressors within the environment that I had been able to previously deal with in part of my life, I'm not able to deal with, and that can then be traumatic, and then feeds itself from that cycle. And so, and additionally, like you know, people can put themselves in other high risk situations where they may be more prone to violence or things like that. And please know that when I say this, I'm not ever saying that someone's asking for it. No one is. What I am saying is that risk happens. And it's important for us to acknowledge that to really understand how these two cycles unfortunately work remarkably well together. So make sure I'm doing okay on time. I can be really long-winded, especially when I don't receive any type of social feedback. So this is me just going. Um, but so substance use in the brain, I want to give like a short rundown of this as well. So and you go back there. There we go. So all drugs of abuse and compulsive behaviors, right? So like gambling or sex I'm I was gonna say cleaning. I know that falls in the OCD category, but realistically, I think there's such interesting connection and similarity there. But these types of addictive compulsive behaviors are connected with dopamine, right? And dopamine, once again, it's motivation, survival, reward, yes, pleasure, yes. But those are because it's motivation and so what we do need to understand is dopamine receptors are also increased in addiction. And so it will be harder for people to have those normative dopamine hits that keep them within a relative level of functioning because they've been going up and down really intensely. Additionally, we have the amygdala. So the amygdala is being activated during cravings. And once again, so if the amygdala is reflexive, it could send signals out. It's not just taking in. This is what is encouraging impulsive, once again, reflexive behavior. So finding something out, experiencing stress is going to activate that HPA axis. Stress hormones are going to be activated. That danger of like, oh, I need to survive is going to happen, even if the prefrontal cortex is like, I don't know if this is really a survival situation. That part, once our limbic system is highly activated, not really online. And so the amygdala is really overtaken. Furthermore, we're going to have deficits in long-term memory and spatial memory, which once again associated with hippocampus. So we're just seeing these overlaps where similar parts of the brain are being impacted. And then additionally, the prefrontal cortex is associated with judgment, decision-making, valuation of like what's important, what's not, awareness, empathy. There's a lot of things with that. And so we do end up negatively impacting the prefrontal cortex, and as such, we need to keep it going so that we have ourselves able to function that way, like in a way that can give us access to overriding our limbic system. So effective trauma treatment. And I promise when I say effective trauma treatment, it will all tie into really what's effective substance use treatment. These really won't be different. Psychoeducation, I will acknowledge I'm a bit biased here. If anyone were to go, that one could potentially go. I like psychoeducation. That's why I have it on there. I like mechanisms. Mechanisms help me understand order of operations. And I'm a big believer in like, I want to figure out the best possible way to help somebody. And for me, that's to follow the research. Not everyone likes that. I'll be honest. I could do effective treatment without psychoeducation, as long as I could do the other three effective. But generally, I don't have anyone who's saying, no, don't teach me anything. So the other one is skills. Skills being really important because we need to make sure that people are able to handle what they're about to go through in their treatment, right? So they have not had skills to confront and to encounter these things that are being brought up. And so if they don't have it, then it absolutely can be a setup for them to go to the one thing that they know. So we do need to look at skills. From there, we are going to look at confrontation or retelling of the story. And then we are going to ultimately go to, from there, creating a new, more positive narrative, one that holds new meaning, new purpose, and a new story for us. And so that's where Brainspotting starts to come in. And so with it, some of you may or may not be familiar with EMDR, but the short version is that Brainspotting was born out of EMDR. EMDR is eye movement desensitization processing. And so there's a lot more than just eye movement. It's a very, very structured therapy. And it like has been significantly helpful for a lot of people. Brainspotting more aligns with me as a therapist. And there are a lot of ways that you could accomplish these components listed on here without Brainspotting. It does not need to be Brainspotting. But the research does show that effective treatment does incorporate these components. And so my way of incorporating these components is through Brainspotting. So EMDR, part of it is that eye movement, going back and forth. And the guy who created this or founded it noticed a twitch in his client's eye at a certain point in the field of vision and just held his fingers there, and rather than continuing that back and forth. And that's really how it came. And it's this notion of where you look affects how you feel. And so having done it for myself as part of the training and everything, really what that's saying is, and this is my handy dandy pointer. If you can see me, this is my pointer. Full transparency, during a Brainspotting session, I look quite stupid just holding up a pointer, but that's kind of what I do. And so what I do is I look for a point where it impacts my feeling. And so, and I'll get to an example briefly, but what I really love about Brainspotting is it's very flexible. EMDR, as I mentioned, has a lot of structure and stages to it. Some people love that. They're like, nope, keep me on task, stage after stage. I like to know where I am, so on and so forth. Me as a person, I'm a very free-flowing, flexible, adaptable person. that suits me better. And so brain spotting is really meant to be used alongside with other treatment approaches that allow for you to incorporate those other components. And so with that, I just real quick, not a lot of people have heard of brain spotting, so I just like to put this in here. This is based on self-survey for following the Sandy Hook shooting. For people who engaged in brain spotting as well as other trauma-based therapies, and what their response was. And so, as you could see, in terms of being very effective, brain spotting for the self-surveys actually came out on top. And don't get me wrong, when it came to somewhat effective, there were a lot that, were around the same range. And once again, my hope is not to say that it has to be brain spotting. It's more of one, that let's include these components that were previously talked about, and two, let's make sure that brain spotting gets its name out there, because it's a worthwhile one. And so with that, there are really two main models for brain spotting. And so activation model is, we are looking for activation early. And so example that I always give to people when I'm like, lying on the couch, they're like, what the hell's brain spotting? I'm like, goodness, this is hard to explain. Is really best way to explain it is an example. So I give the example of my fear of heights. And so for that, I go ahead and I say, okay, so if I were working on my fear of heights, I would ask me to talk a little bit, get it going. And so I'd share, okay, this is what's going on for my fear of heights. This is a time when I experience it. And I would allow for that activation to happen. I would notice what happens in my body. And the therapist would be asking me, tell me about what's going on in your body. And so I'd tell them, okay, well, my palms are getting sweaty, my heart rate's going up, I kind of feel some tension in my neck. I feel some tightness in my forearms, right? Whatever that may be. And the therapist would be like, okay, we're going to lean into that. And I tend to use what's called outside window, which is really, it's more dictated by, it's inside window, which is more dictated by the client telling us where they're experiencing the activation. Outside window is when I try to see from the client's facial and body responses where they're experiencing it. But so with outside window, an inside window would look like, okay, so notice what it feels like here. And I'd look over here and I'd be in touch with it. Then we'd move it to the middle, be in touch with it, move it over this way, be in touch with it. And then I'd ask, okay, where did you notice it the most? And then we'd go back to where that is. Let's say I felt the most over here, I had my little pointer up and I'm looking over there, and the therapist would fine tune it for me. Where do you feel it the most? Go up X, Y, you can go on the Z axis as well. And so with that, they would just go. And then once we have that spot, we lean into it. We allow for the activation to happen. And really what we're doing is we're allowing for desensitization. And so that is part of that confrontation. And desensitization, it's not meant to minimize client's experience. It's meant to empower the client's experience. It doesn't mean that this is no longer an awful event. What it means is that we are essentially training our bodies to be able to handle the stress, and therefore ultimately reduce the stress. So we could use the activation model. Sometimes people are really sensitive, and we really do want to stay within a window of tolerance. That's a languaging that I was taught to use in brain spotting. And that's where sometimes the resource model, and that really setup is very, very similar. Really the main difference is we're going to find a groundedness, a sense of calmness within the body, and then I will activate. So let's say, for example, that my fear of heights triggered panic. The second that I start going and leaning into it, it's too much for me. So it may be where do you notice the most calm in your body? I go, okay, so I feel the most grounded with my feet touching the floor. And go, okay, lean into that. And we do exactly what I did here, but really noticing with these, notice if you feel more or less grounded. And once again, finding that spot where my feet are most absolute at peace. And then from that point where we have our grounded resource spot, from there, we will then engage in activation. And that's what I love about this is um, rather than moving away, which trauma and substance use, they both are really, really good at having us move away from what's happening for us. Brain spotting sets a stage for us to be able to move into it. And people might be like, wow, okay, so like, then what? And I say, well, so when we start talking about desensitization, as I said, we are really building a skill. And so when we look at building a skill like this, what we have to be able to do is set ourselves up so that we could progress. So let's say, for example, I had a goal of benching 400 pounds, and you are like, with those twig arms, I don't think so, Danny. You'd be right. That would be absurd for me to just go and be like, well, I'm going to try it out. No, you got to start from where you can. And so when I start with people, I tell them like, look, I'm going to have my clock. Like I'm going to be paying attention to that as well as to you. I'm not going to hold you in this too long. I heard from someone, I didn't have any way to fact check this, but I did hear from someone in the brain spotting community that the founder of brain spotting has been doing 10-minute sessions for brain spotting. Real quick burst. And that really would line up with what the science says about desensitization and doing bursts of stress, as opposed to leading into prolonged or chronic stress. It could be unhelpful. So you really find it in incremental times, and then we broaden that up where they become more and more skilled. So that is really a very, very short version of brain spotting. And like, once again, we tie the other components into it, and brain spotting can, like, as people are processing through and they're just like following their experience during an actual brain spotting session, there's oftentimes a lot of silence and like direction of like being in touch with what's going on with their body, their emotions, and if thoughts are coming up, like allowing them to notice all of that from a non-judgmental. And sometimes during that process, narrative may organically happen, but narrative is really like, it's a story that like comes from our prefrontal cortex. And so oftentimes at least. And so we do need to be able to access those parts. And that's why I believe, when I look at the science, why the narrative does really need to come after the desensitization would be because the limbic system, when it's too highly active, will override the prefrontal cortex. Once our limbic system becomes more adequate and skilled at dealing with all of this, then we could get our prefrontal cortex back online, and we could really learn this narrative, and we could really start thinking about like, how can I create meaning and purpose with my story? And how can I tie that back to the traumatic event of really showing that, like, survivor, essentially, like, I am someone strong. I am someone who's been able to confront this. I am someone who, despite this happening, still finds joy in my life. Because by tying it back, we also aren't running away from it. We show that, like, with this year, we're not eliminating it from our past. We're acknowledging it as part of our story as a whole and our growth as a person. Of course, we would love to grow without having to have gone through trauma. And sometimes we just don't have that choice in life. And so when we have that, like with that prefrontal cortex, it really can be those breaks that like allow for things to slow down, challenge, and change our trauma. And then so the last thing that I really wanted to touch on, which, oh man, as I do this, like, there's so much more I could go into. I was worried about time, making sure that I had enough. What I also love about brain spotting and the way that it ties into substance use is flexible. So someone may have a day where they're like, I'm feeling it. I'm feeling triggered. I'm feeling sensitive. I'm activated, whatever verbiage they would like to use. And they're like, I just want to avoid right now. And I get it. That's a pretty natural thing for their brain to want to do in that point. And what I could do with brain spotting is say, you know what? Maybe today we aren't focused on the trauma, and we do brain spotting focused on the cravings themselves. Like if you're having cravings or whatever you're feeling sensitive, we could do it based on that, because that trauma could scare them, and it could scare them into terms of like, oh, I'm afraid that I'm going to use. And so with that, there are ways to do it. And so, um, as I said, you could just lean into, okay, let's focus on your sensitivity, and we could do brain spotting, find that spot, and really process through that, remove those barriers. I actually just did this with someone, and she told me, she was like, I want to avoid right now. And I was like, you're here. Like, how amazing is that? Are you open to us just processing the sensitivity? And she did that. And end of the session, she's still sensitive. Yeah. And she also said that she felt better. And I was like, let's just take a time to note that you did the exact opposite of what you wanted to do, and you felt better. And so we really got to capitalize on that. And another way to do it with the cravings is what's called the Crocodile Setup. This is from Dr. Roby Abels, and she's a PsyD based out of Australia. The short version, if you ever want to go on her website, I believe she like writes out the story for the Crocodile Setup. It's great, love it. But the short version is that she viewed addiction as crocodile. It's an apex predator. It is patient, and it will wait to strike. It's going to learn your patterns, it's going to learn your movements, and it's going to wait for you to make a mistake. And so that's your view of addiction. Is it's a crocodile, it's an apex predator, and it will wait for you if you're not careful. And so um, this setup is it's part of what's called rolling brain spotting, but the specific setup is really using three setups, and one is like used to um, activate where people are feeling euphoria associated with their use. One is about the consequences of their use, and one is vision of a future without substance. And so like I'll like, put up tape or something, or they could use like a natural spot that they look to or something for like one spot, and then I'll hold the second spot. And then later on, like I tend to oscillate between the two until they really start combining the two of them. And then I tend to like lean in towards the third spot and have them identify that later in the session. And it does a really good job of mitigating cravings. And like every time I've done it in session, I've actually not had a time people did not rank a deep in cravings when doing this in session, and then also worked on the skills of how to apply that outside of session. So once again, that is like a abbreviated version of honestly a lot of different things. I hope that I was able to tie it all together. And I do want to be mindful of time. I see that we're at 5 till 1, and so I wanted to open it up for questions with a really creepy picture because I really like comic books, and that's really all that's about. Yeah, so questions or anything that I could support. Let's see. Not seeming like we have questions. I hope that people feel free and comfortable to ask if you do have any. Um, Additionally, if you would like a copy of this presentation, please feel free to ask me. I am much more of a verbal person. And so when I make a presentation, I do make it with like the intention of me being able to elaborate on things. And if you do have any questions in terms of utilization of brain spotting for cravings, for just general things, like, I mean, I use it for anxiety, depression. I'll tie it in if it feels right. And the client, it seems like it'd benefit the client. I'm more than happy to answer questions. So if people want to grab a hold of my email, more than happy to answer questions around that.
Thank you, Danny. Can you hear me okay?
Yeah, I can.
Okay, great. Thank you so much for taking the time to present on this very important topic. And we invite people who have had a chance to participate that if you have questions, you can follow up with Danny after. It looks like we do have, yep, Carolyn Hall says, I really appreciate the brain spotting skills. Thank you, Danny. And Again, thank you everyone for participating in the Aspen Ridge webinar series, and we look forward to getting you our next upcoming workshop in May, which will be on working with active duty military families and substance abuse. So have a great day, everyone. Thanks so much.
Thank you, everyone.